and joining with us as we're going through this. As Roger mentioned, Lauren and I just want to take a moment and give us a little bit of perspective as we walk through this conversation. So what we usually do is start globally and work our way down, if you've ever sat with us before. So there are, starting globally, right, there are over 45,000 cases of monkeypox across the globe, and the United States is leading in the case count with over 16,000, well, not closely at this point, followed by Spain, Brazil, Germany, and the United States. Globally, we have 12 deaths, but the US currently has no reported deaths. And you can see by the different colors of dots over there, the blue dots are countries that have historically reported monkeypox, primarily in that Central and West African area. And the yellow are those which have not historically reported monkeypox. As we dive down into the United States view, at this point, every single state in the United States has had at least one case. Texas has a little over 13,000 cases, or sorry, 1,300 cases. We are the fourth highest case count of the states, preceded by California, New York, and Florida. We also want to look at that national level. The CDC has put some additional information on their website. So now we can see some updates about testing. What you can see here are the positive tests in dark blue, negative test results that have been sent to CDC in lighter blue, and you can see that orange line is a positivity rate. So you can see right around July is when those commercial test labs started to come online and also become available. So we can see that the volume of testing that's happened has dramatically increased. And as that's happened, the positivity rate has gone down. So we now have a cumulative positivity rate across the nation of 32.4. And I would say that this data in the most recent days is likely underreported just due to data reporting lags. And again, looking across the United States, almost all the cases are currently in the male population. Most of them are in that 31 to 35 age group, but they're generally sort of that young adult to sort of middle-aged adult. And the distribution of race ethnicity has shifted over time from when we very first started, but has remained relatively stable over the last few weeks, with most reporting as Black or African American, Hispanic, or white. CDC has also put up some of the most common symptoms that have been reported. These would not be for all cases, but only those that they have data available for. So the most common is rash. That is understandable because rash is generally a required symptom in order to be tested. But the other common symptoms are those that are generally nonspecific, so malaise, fever, chills, headache, etc. And some of those more serious symptoms, when we talk about rectal bleeding or tenesmus, are being reported less frequently. The other thing that they've shared, if you are an HIV provider or work with the LGBTQ population, you might be familiar with the American Men's Internet Survey, which is an annual online survey of cisgender, gay, bisexual, same-gender love, and other men who have sex with men in the United States. And its main goal is to monitor trends in sexual health to improve public health services for HIV prevention. And so CDC partnered with Emory University, who runs the AMOS survey, to do a one-time survey outbreak on how respondents may have changed their sexual behaviors due to the monkeypox outbreak. So the preliminary information is showing that about half of the respondents reported doing some behavior change, including reducing the number of sex partners, reducing their one-time sexual encounters, and reducing sex with partners met on dating apps or at sex venues. So we are seeing some behavioral change in response to the outbreak in about half of these respondents. So next we want to move away from that global picture and drive down a little more locally. So you can see here that in Texas, they have their cases divided up by what's called public health region. Houston falls within public health region, what's called 6-5 South. And so Public Health Region 2-3 North, which has the largest number of cases in Texas, is up in the Dallas-Fort Worth area. 6-5 South, like I said, is in the Houston area. And of those in 6-5 South, Houston itself, the city of Houston has 3,076 cases. So we account for nearly 30% of all the cases in Texas. Again, our age group breakdown across Texas is very similar to what we see at the national level. And again, predominantly male, again, similar to the national level. If we look within our Houston data, you can see here, it's a little bit of a busy slide, but what we've got over here are positive people in blue, negative or positive tests in blue, negative tests in pink. And what we've got essentially sort of a rolling average or a 7-day centered average positivity in this red line going through. So similar to what we saw at the national level, we saw a vast increase in test results happening in July. And our positivity rate is a little bit higher than the national level right now, looking at around 48.4%. So let me go ahead and turn it over to Lauren Hopkins.
Thanks, Kirsten. So this is the data that Kirsten just mentioned was from our disease surveillance system, our reportable diseases. So this is the actual drill down of cases in terms of the age group. So the and sex and race and ethnicity. So the trends in age are consistent with those reported by CDC and DISHs, with most cases, as you can see in the upper left-hand purple slide, occurring in individuals in their 20s to 40s, mostly in their 30s, actually. And then we have similar trends in sex, also consistent with CDC and DISH's data, and that most of our cases are currently in the male population. You can see on this slide, we have just 1% in the female group. And then race ethnicity trends also follow similar patterns as known, as shown by CDC in the earlier slides, and that the majority of the cases are distributed among white, Black, African American, and Hispanic populations. So the number is in our contact tracing team, we're keeping track of the number of contacts generated per case, and in the left-hand corner there is a list of that is 0.57 contacts per case. Next slide, please. We also look at the case counts, again, from the same disease surveillance system in space. And so this is a map of our cases. We've suppressed zip codes with cases under 5, but in the highest zip codes, the ones with the highest case counts are in that dark blue there. Next slide, please. Did you want to cover this one, Kirsten?
Sure. The last thing that we really wanted to do was take a look at co-infections between monkeypox positive persons and persons who are also HIV positive. So Lauren's team made a really nice dive into that information. And what we found is that 38.9% of people who are positive for monkeypox are also HIV positive. So we have, 60% or 61% that are monkeypox positive are HIV negative. But within this smaller group, within this 40%, if we look at those that are monkeypox positive and HIV positive, 75% of those are virally suppressed. We have some where we weren't able to determine viral suppression, but 19.23% of these folks that are monkeypox positive and HIV positive are not virally suppressed, which has a couple of implications, one of which is that they may be harder to reach for treatment or vaccination because they may not be seeing their provider on a regular basis. And when they're having encounters that may be opportunities for transmission for monkeypox, those are obviously may also be encounters that are possible transmission events for HIV and other STIs. So with that, I will stop sharing and turn it back over to Roger.
Well, thank you for that information. It's really great. So next up, we have both our local health authority, Dr. David Purse, and our deputy local health authority, Dr. Janina White, to speak about the current eligibility requirements for the monkeypox vaccination. Thank you.
You're on mute.
There we go. Works better when I come off mute, doesn't it? Okay, so the our current eligibility requirements for the city of Houston, we've expanded them just a little bit lately. We're pretty consistent with Harris County, but just go over those for everybody again. Hang on, I clicked on the wrong click. Make sure I give it to you the right. So obviously, it's anybody who we have confirmed to have had a higher intermediate risk contact with someone who has monkeypox. So this is through contact tracing. We'll reach out to that individual, let them know that they're identified as a high contact, a high risk or intermediate risk contact, and offer them vaccine. We are also still working with some of the events or venues where there is someone where we know had monkeypox but participated in an event, and we're working with those event organizers. And we've had a couple of clinics, if you will, to offer vaccine. But then also to the more broad community, anyone over the age of 18, any man who has sex with other men. There were before we were saying if you were MSM, but if you had a encounter in the last 21 days, so now it's any MSM, any man who has sex with other men over the age of 18, anyone who has had a sex partner who they suspect is having monkeypox because you notice rash or sores, or perhaps they told you on outside of our information network that they may have monkeypox, you can get vaccinated. We've also opened up to anyone who is HIV positive or is on pre-exposure prophylaxis. And then finally, anyone who's had a diagnosis in the last 3 months of gonorrhea, chlamydia, or early syphilis would qualify for getting vaccine. And I will also just point out that right now, if you call our appointment line at 832-393-4220, we have plenty of appointments available throughout next week, and would encourage folks to go ahead and call that number to get an appointment set up. Dr. White, what did I forget?
Absolutely nothing. That's perfect. Back to you, Roger.
Okay. All right. Well, thank you both for joining us. I appreciate the added information. And I will say I just dropped the link to the City of Houston, Houston Health Department monkeypox webpage in the chat, and all that information about vaccines is available there as well. All right, so next on the agenda, we have actually our Chief Physician for Medical Support Services, Dr. Latasha Gale, who will be joining to present a case study on monkeypox.
You're on mute.
I tell you. All right. Good afternoon, everybody. It's my pleasure to present to you all a case. I know as clinicians, this is the interesting thing and the part that you live and breathe and see on a day-to-day basis. So just wanted to give an example of a case that actually you would not maybe have suspected much. So what we have for you is a 25-year-old, oh, if I can share your, a 25-year-old male living with HIV who is on medication. Whether or not he was virally suppressed, we had no data about that. He presented to one of our HHD clinics on 7/27 as a referral from his HIV primary care physician for an abnormal RPR. The abnormal RPR was done after a visit with his HIV primary care doc on 7/8. So on 7/27, he presents to us. His initial RPR was 1/16, and he was FTA-ABS positive. He presented to us, and of course, in our clinic setting, we repeat labs. He had a repeat RPR of 1/64, and his TPPA was, of course, positive. As is important in a sexual health clinic, a very thorough sexual health history and a complete physical. So the sexual health history, basically, he had just come from an event in Florida that was a relatively large LGBTQ plus event. He reports having multiple partners, both male and female, and he reports having vaginal intercourse as well as anal insertive and anal receptive intercourse. He had no particular symptoms when he came to see us, other than he needed to follow up for this abnormal lab. Of course, not only very important in the sexual health clinic when you see someone, is to get this a very thorough history, but to also do a very thorough exam. So we all know that syphilis can have many presentations. So this exam is done closed off. The gentleman basically had a normal exam with the exception of a very incidental finding of a rash. And the rash, this is not the exact rash. I did not get the gentleman's consent, so I cannot show you the exact rash. But the rash, I hope you guys can see this picture. This is basically what it looked like. And it was so indiscreet. It was not just a solitary lesion, but he had these lesions on his anterior chest and on his upper back. There were, most of them looked just like this, but there were a couple that were umbilicated. The reason that we decided to do a collection of this particular lesion was because of the patient's history. The rash was a bit unusual. The umbilicated lesion sort of was a bit of a key for us. I was doing this exam with one of the nurse practitioners who is in training now, who did a very good job. And her question to me, as many of you may ask, and looking at it, well, Dr. Gail Lowe, do we really need to swab? Do we really need to swab that? It doesn't really look like anything. And because of our climate, I know, and having always great conversation with our lab staff and Dr. Siegler, who's the best teacher about lab things ever, that we just collected. And so I said, you know what, let's just be cautious and go ahead and do the collection. We collected multiple samples as per lab criteria. And a couple of days later, one of the three lesions, one of the lesions was indeterminate, and the other lesion was positive for monkeypox. So this young man was advised of the diagnosis. He was advised to monitor himself, advised to report to his partner. His partner did get vaccinated. He has since then, I have found that he was found to be actually a Harris County patient. So EPI followed him in Harris County. But our clinician, being a good clinician, has followed up with him over time. And he actually had a very short time where those lesions opened up, got a little bit worse, and then crusted over after about a 2.5 week period of time. So he's better, he's at work, and no further sequelae as a result of this particular monkeypox diagnosis. So I just thought it was a great case to present because the rash was not glaring. He had lots of risk factors. So as we all know, the term that was always said to me is you look at the gestalt, which means you look at the entire picture. So it was not just about the lesion, but it was about the gentleman's history, his physical, as well as the lab report. And if anybody has any questions, happy to answer.
Thank you very much, Dr. Gale. That was very interesting. Well, that actually concludes the presentation portion of this event. Like I said, we wanted to leave plenty of time for questions and answers. So we'll now open up the floor to any of your questions. In addition to just the presenters who are still available, we also have experts in laboratory services, immunizations, healthcare promotion and education, and special populations outreach and others available as resources as well. So you can either drop any questions in the chat or use the raise hand function, or if there's a moment of silence, just chime in. We want to hear from you. And while we're waiting for questions, if anybody from HHD here wants to chime in as well, please feel free with any pertinent information. Okay. All right, Nicole, you have a question?
I certainly do. Good afternoon. Happy Friday to all. I'm Dr. Nicole Robinson. I'm an advanced practice nurse here and the chief nurse at the University of Houston. Can you hear me? Excellent.
Very faint.
Okay, I apologize. I'll project a little bit more. Is that better?
Yeah, very much.
Okay. We are, of course, in process of working on protocols here, more information to come. But from a collection perspective for our clinic, I wanted to confirm if we do have cases that are highly susceptible and we make the determination to either refer them over to the city, or if we end up having collection capacity here through Quest, let's say, I want to be sure that once we have appropriately prepared ourselves to collect, it is okay to not disrupt the roof of the lesion, correct? We are just trying to agitate the area a little bit to get a sample, but I want to make sure if it's already in a stage where it is crested over, what would be the appropriate protocol to get a viable sample? My understanding is don't disrupt it, but get enough of the site, both sides, multiple sites if they present as such, as Dr. Gale stated, and pack appropriately and send off. But is that correct? Do not disrupt the roof if it's already scabbed over. Thank you.
So yeah, I can start. So I want to say on that link to the website, our current collection guidance is on there. But yes, so everything I've heard so far is they say to vigorously swab the area, but that doesn't necessarily mean you need to unroof the lesion. Just vigorously swab. CDC has told us that the scabs themselves are very high viral load, so just by swabbing that, you should get something good to test. Also, the current guidance is to, and correct me, Melan, if this has changed, that they want 2 swabs per lesion, but they also do it collected separately. And the reason for that is as a backup to send to CDC if we need to for testing. But also they would like you to do multiple lesions if possible, ideally. Now, of course, if you can't do that, it's not going to work out. That's fine, but that's the current guidance.
I appreciate the feedback. Thank you so much.
And Nicole, along those lines, you guys have the PPE, correct? So you would be in PPE.
Correct.
Okay, great.
And I'm sorry, you said you're with the University of Houston, correct?
Correct.
So, if you do need help in setting up, getting started with some collection materials, and that we're happy to give you some stuff to get started, while you source your own stuff. You can reach out and we'll be happy to help with that.
Excellent. Is there a particular contact, or may I reference what you've shared in the?
Sure. Yeah,
the
I'll
link?
drop my email in the chat, and you can just get in contact with me, and I'll be happy to connect you with the right people.
Thank you so much.
Roger, there's some questions in the chat.
Okay, thank you. Okay, I see. So after how long can an infected patient get vaccinated? So what's the current guidance? So if someone is diagnosed with an infection, how long are they still eligible for the post-exposure prophylaxis, I think is the question.
So this is
Well,
Kirsten. Let me,
Go ahead,
well,
Kirsten.
okay, I was going to say, generally, if you have someone who is infected, they are already developing a natural immunity. And due to the limited vaccine supply that we're still dealing with here in the United States, we would recommend that they go through that natural immunity rather than use a vaccine dose that might be available for someone else. But there is not necessarily a contraindication from a medical perspective. Dr. White, I don't know if you want to expand on that or perhaps talk about TPOXX for the infected patient as well.
And I see
No, you're
Joy
right.
added in some
Yeah.
comment as well, that as of May 17th, it's not recommended for anyone who has a diagnosis.
Right. Currently, our CDC recommendations are individuals who are monkeypox positive would not be receiving the vaccine, and they would just use their natural immunity from what we know right now with regards to this virus. However, to your point, Roger, with regards to therapeutics, there are options for therapeutics if an individual would warrant having to receive medication. A lot of individuals, it's just symptom management, supportive care, antipyretics, topical cool baths. But there are certain individuals that will need more than just really supportive care. In that, primarily, we've seen pain support is one issue that individuals will often push into hospital or emergency departments for pain management. And then again, antiviral for TPOXX, tecovirimat, has a both PO and IV formulation. And we've seen that used for individuals whose symptoms, particularly their skin lesions, are such that you're trying to really help them with the course of the virus and the time of being symptom and ill. And so we've seen oral TPOXX prescribed by many of our partners for their patients, and then we've had a few now who have been hospitalized that needed IV preparation.
I want to add something to it. So everything which has been said is exactly correct. I just want to make sure people understand that the recommendation for not vaccinating somebody who's already symptomatic is not just about conserving vaccine. Remember, for the most part, people who become infected with monkeypox are going to have a mild clinical course. There are some who will have a difficult clinical course. And once that happens, the vaccine isn't going to, they're going to need TPOXX, they're going to need more aggressive therapy than what a vaccine would provide. The other thing is that the vaccine, if somebody is symptomatic and you begin vaccinating them, that vaccine is not going to have a clinical impact until 6 weeks later when they get their second dose and 2 weeks beyond that. So it's not just about conserving vaccine, it's that their own immune system is going to respond more quickly and more effectively than the first injection of their vaccine. And so I don't want anyone leaving this conversation thinking, oh, well, they're just trying to conserve vaccine at the expense of the patient. It's not that at all. It's that it's probably not going to help at that point very much. And if they do have a difficult course, they're going to need things far above and beyond and more powerful than the vaccine would offer.
Okay. And I see from R. Williams, can you provide guidance of, was that for collection guidance, or I think something got left off?
Can you hear me?
Yes, ma'am.
Hello?
Yes.
Okay, yes. My name is Rolanda Williams. I'm calling from the jail. We have an area where inmates are quarantined in their cells 23 hours a day, but they are allowed to come out 1 hour, and they're using the same phones and shower areas. I'm going over now to speak to them. We're going to enhance our cleaning process, but I wanted you to speak on what you recommend.
So I'll take the first stab at that, and I ask the rest of the team to join in. We do recognize that the virus can be spread through fomites. So fomite is as everybody knows, any sort of inanimate object. Historically, and from the experience with smallpox, is it needs to be something more along the lines of a cloth. So a blanket, a sleeping bag, bed sheet, something along those lines. So a telephone, which it sounds like you're describing, would probably be the fomite of greatest concern. Now, the virus does have the ability to remain live on inanimate objects, but simple cleaning of the phone before and after every use, I would think would be sufficient. And then again, it kind of goes to the particular, when they get this 1 hour, what other objects may they be coming in contact with? So they probably should be, and I know are they in there one at a time, or are they in the groups of 5 at a time? You'll need to sort that out.
It's just one at a time. It's just one at a time. Mm-hmm.
All right. So yeah, they probably needs to be cleaned, certainly in between every individual going in there, but you don't need to go in there with, power wash steam in level A protective suits to do it. But I'll leave it up to the rest of the team. What would we recommend?
Thank you, sir.
Hey, good afternoon. This is Kirsten Short again. So I just want to echo some of the pieces that Dr. Peirce has said. CDC has come out with some updated guidance for monkeypox infection control in congregate settings. Some of that would apply to some of your scenarios in the jail, although you've got some additional factors to consider in there. But as Dr. Peirce mentioned, a lot of those steps in cleaning and disinfection that were put into place with regard to COVID procedures are going to carry over and also provide a level of cleaning and disinfection for monkeypox as well.
Thank you.
And in the chat is some guidance. If it's a porous surface, like a carpet or something, that's a little bit different. So Joy put some stuff into the chat to help with that.
Okay. Yeah, and I just found that link to the congregate advice as well and dropped that. Okay. All right. Not seeing anything else coming up. If anybody else has anything, please, we want to hear from everybody. Also, if you're on this call right now and you have any recommendations for topics you would want to see covered in the future, we're very interested in getting some feedback, on that as well. This call is for our guests, and we want to make sure that we're giving you information that you want and need. Okay. Well, in the let's see, we have hand up. All right, is that Naomi Lockett? You have your hand up. Question for us?
Yes, my name is Naomi Lockett, and I also work here at the jail. And I wanted to know what your thoughts were on if we should use screening questions at intake, or when we are transferring patients out to other facilities. We've now began to get requests to do screening questions. And so I want to know if you think that that's useful for us either at intake or when we're transferring folks out. And if so, if you could give me some ideas on where we could find screening questions that you think would be most appropriate.
So let me jump in real quick, because I want to say one thing for the folks from the jail. I just want to applaud you. I don't know that most people in our community understand what a heroic and fantastically effective job you all did in containing COVID inside the jail. If there was a target-rich environment for that virus, it's an overcrowded jail. And it is amazing that here we are pushing 3 years later. Our records show that there are only 8 deaths related somehow one way or another to the jail. Of the hundreds and hundreds of deaths in our community, one of the places that we worried about to a great deal was the jail. And your team, we were there in the trenches with you just at the very beginning, but you carried the heavy load. You all figured it out. And for anybody who, I've not been incarcerated yet, but I learned so much about how complex the management is of a jail. It is completely beyond the complexity that I could have ever imagined. And it is really remarkable what a great job that you all did. And you know, I am impressed and thankful and proud of all the hard work you did. So the quick answer to your question is going to be, I think it is entirely appropriate to start some screening questions. I'll leave it to the rest of our team about what specific questions have been used, or if there's references for something like that that may help you. But I would think it would be entirely appropriate. And then, of course, the question after that is, well, what do you do with the answers, right? So that's going to be more particular to your situation. So you have somebody who's coming in or going out, whatever the situation is, and they answer in the affirmative to your question. You know, what are you going to do after that? That may be more complex than deciding whether or not to ask questions.
Yes, thank you, Dr. Person. We appreciate those kind words. You guys helped us tremendously, so thank you.
Hey, so this is Kirsten again. First of all, hello, Dr. Lockett. It's been a little while since we've chatted, but I do recognize your name there. We do on our website, so on the Houston Health Department website, we do have a monkeypox page. Within that monkeypox page, we do have a tab about provider resources. And within those resources, we have a draft or suggested version for communicable disease screening or risk assessment. And so that is something that was developed both with COVID as well as some options for monkeypox. And so that is certainly something you may not want to use that directly as it's written, but certainly gives an idea of what you might want to start with from a screening perspective.
Thank you, Kirsten. I appreciate that.
And while we're waiting on questions, is there any information anybody from any of our health department team would like to share with the group? Anything that came up in this conversation? Any of the questions or any of the presentations?
Hey, Rogers Thomas. I did want to echo one thing that Dr. Person mentioned as it relates to definitely the jail being the unique type of setting that it is. But we've seen what's been successful thus far with our congregate settings is, yes, having some form of effective screening process. You'd be surprised that if you can capture that person at the onset of identifying either presumed risk factors, whether it's just based on behavior and or recent exposures, how you can better coordinate that individual with via isolation or any preventive measures or treatments you can offer. And same thing when you move clients. We've dealt with that with some of our other facilities where a person may go from one location where they're initially brought into intake and then sent somewhere else. Then we see infection go from one building to another. But how did this happen? Well, it stemmed from this one individual that either was never captured through a screening process, or when they were, that handoff necessarily may not have happened. So it is critical that if you can capture that at the onset of intake or movement throughout the facility, it gives you a chance to be able to get in front of the situation. So it is a critical tool, especially from my perspective of what I deal with the responses